Hello everyone, how are you all? Okay, all right guys, so let's start our tonight's session. So we are going to discuss pediatrics class 2 today. Okay, so have you guys got any time to go through the pediatrics class 1? Great. Okay, so what we're going to do is we're going to actually go through pediatrics class 2, which will start from pediatrics infection. So I told you that pediatrics infection we are going to do from John Murtagh. So let's start with that. So John Murtagh 8th edition, if you open up the chapter 86, which is in page 988, you'll get the common childhood infection chapter there. Okay. Okay, so let's move on because there's a lot to discuss in pediatrics. We will be a little bit faster today, and I hope you can catch up with me. If there is any concern, anything that you have, just ask in the chat box. Okay. So chickenpox is the first one from childhood infection. Now this chapter is super important. There is a lot of questions which come from here, so you need to know it really well. So all of you know what is chickenpox. It's a infection caused by varicella zoster virus, and it is spread by mainly the droplets, so infectious person coughing, sneezing, or even touching the fluid or the rash. The primary infection by this virus causes chickenpox, which is varicella. And once a patient gets chickenpox, this virus will stay latent in their dorsal nerve root ganglia forever. Sometimes, whenever they are stressed, their immunity goes down, that virus can get reactivated and it can cause another condition called shingles or herpes zoster. Chickenpox is more common in children, whereas herpes zoster is common in elderly patient. But again, shingles can happen in a child. Excuse me. Okay. So clinical features. So what are the clinical features of varicella? So first of all, clinical features of varicella, patient who are children, they don't have any prodromal symptom, which means that children will not get any flu-like symptoms, no malaise, fever, nothing. They just start with a rash. Rash has a centripetal distribution, which means it starts in the center of the body. So mainly starts in the center and then it goes to the arms and legs. So it is centripetal distribution. Now, the rash has a specific feature, which is it is a vesicular rash. And the vesicular rash, mainly, it affects like the vesicular rash is mainly the rash will be full of fluid or blistery rash. Okay, so if you see a blistery rash, that is what we call as vesicular rash. And rash has this cropping phenomenon. So in a same patient, you can get multiple rash, like someone can have vesicle, some can have a bit of papule, some can have crusting. So all lesions together. So that's a typical presentation for varicella. So voice is not clear. Is it for everyone? I haven't done anything. Voice is either good or bad. There is echo. Okay, let me see. Just 1 second. How about now? Is it okay? Okay. All right. Move on. Oh, good. All right. So varicella infection, that's what we are discussing. So children will not have any prodromal symptom. Adult can have some prodromal symptom and then they can have the rash. But chickenpox is mainly common in children. So again, a vesicular rash where mainly it's a fluid-filled blistery rash starts in the trunk, or that means in the body, and then it goes to the extremities. Then you would think of chickenpox. So what are the complications of chickenpox? So chickenpox, the main complication is that those rash sometimes can get secondary infection by a bacteria. Most of the time, either a staph or a streptococcal infection. That's the commonest complication. Sometimes varicella patient can have pneumonia. They can have eczema herpeticum. They can have thrombocytopenia. These are not really important. But there was a question a long time ago about acute cerebellitis. So if you see a patient who has been diagnosed with varicella or chickenpox, and suddenly the question says that the child is complaining balance problem or having difficulty to walk, difficulty to keep the balance, which is ataxia. If that happens, then you would think of the likelihood of acute cerebellitis, which is a complication of varicella. Okay. And it looks something like this, as you can see. Most of these lesions are crusted lesions at the moment, but initially it will be fluid filled. And this is the centripetal distribution, so mainly more in the trunk, and then it will be also very pruritic. So the child can say it's itchy, and child will scratch it, but not that much in your arms or legs. Now there is a condition called congenital varicella syndrome. Congenital varicella syndrome is if a mother gets varicella infection during pregnancy, the baby can also get congenital varicella syndrome. And congenital varicella syndrome mainly comes as ocular anomalies, neurological malformation, and it mainly happens if mother gets infected in the second trimester. We will discuss that in our obstetrics class, that what is congenital varicella syndrome and all about it. Treatment. It is a viral infection, so treatment is just symptomatic treatment, no need of any specific therapy, not even antiviral to everyone. So only time you would choose antiviral in a chicken pox is if a patient has immunocompromised status, so someone who is already immunocompromised, or if it is an infant who can get a complicated chicken pox, for those patients, you can start the antiviral. But apart from infant or immunocompromised patient, you would never start antiviral treatment. Okay, so the symptomatic treatment, you can go through this, it's not needed. Now, antihistamine can be prescribed if the child having any itching. If the child having secondary bacterial infection, then you can give them antibiotic, which is either flucloxacillin or dicloxacillin. Now, very important for exam is school exclusion. So school exclusion, sorry, someone just did that, I think. Okay, so school exclusion is very important for varicella. So, and not just for varicella, for all these childhood infection, school exclusion comes in exam. So it is recommended to have school exclusion for 7 days or until the blisters have dried. Okay, so usually 5 to 7 days school exclusion should be done. So this is a chart or table 86.3, which is a super important for the exam. It gives you all the school exclusion time. So you can see measles, 5 days school exclusion, glandular fever, no school exclusion, mumps, 9 days, pertussis, 5 days. So all of these that we are going to discuss today, they have given it in a chart. So memorize all of this school exclusion time because it comes in exam a lot. Prevention. So can we prevent varicella? Yes, we can. So varicella can be prevented by the vaccine, but the vaccine is available from the age of 12 months up to and including 13 years. So the live vaccine that we give for varicella, it is mainly so there are 2 doses. One dose is given at 12 months and another dose is given at 18 months. So this is like routinely given to every child in Australia. So the prevention is by vaccination. Now, other thing is that, is there anything that we can do to prevent the infection in a contact? Let's say your patient has got diagnosed with chickenpox, and you come to know that in that patient home, there is an immunocompromised patient, maybe a patient who is an organ transplant patient, or in that patient home, there is a neonate. So these patients are high risk. So only in contact who can get a really complicated infection from varicella can be treated with immunoglobulin. Okay? So again, antiviral is only for immunocompromised patient if they're already been diagnosed with varicella. Now, if there is a contact who is immunocompromised, then for them you would give immunoglobulin so that they don't catch the infection. Does it make sense? It's a bit tricky thing, but if you understand this, then all other things you will understand very easily. Yes, we need to know when to vaccinate. So the normal usual vaccination we should know. Okay, let's repeat. So first of all, chickenpox is a viral infection. So in a normal patient, you would not do anything. You would just go for symptomatic treatment, right? For someone, let me just draw, so that will be easy. So for someone who is, now first thing is what is index case and what is contact. You have to understand that. Index case is who is already having an infection. And contact is who doesn't have the infection at the moment, but they came in contact with this index patient. So they have a risk that they can catch the infection. Does this make sense? Okay. So index case, for someone who is not immunocompromised, there is no need of any treatment. But someone who is immunocompromised or infant, that patient will be treated with an oral antiviral. For contact, nothing. Usually for healthy contact, there is nothing you need to do. But if there is a contact who is immunocompromised or a neonate, just a newborn, For them, you would give them varicella zoster immunoglobulin so that they don't end up getting the infection. Okay? So that's the idea of all of these things. Moving on to measles. So measles is a highly contagious disease. It is caused by RNA paramyxovirus. And again, it also is spread exactly the same way. So respiratory droplet. So measles can also give you a specific spot in the oral mucosa, which is called Koplik spot. And Koplik spots are tiny white spot opposite to the second molar. So that's one of the important findings that we can get in a measles patient. So if you see the buccal mucosa and you see white tiny spots like a grain of salt opposite to their second molar tooth, that's Koplik spot, and it can be found in a measles child. Always remember that measles child usually will have 3C first. So there is always a prodromal stage followed by the rash stage. So in children who gets measles, they get 3C, which is cough, coryza, conjunctivitis. If you look at the picture, you'll see that they're having cough, they have coryza, which is runny nose, and they get these watery eyes, which is conjunctivitis. So cough, coryza, conjunctivitis, followed by a rash. Now the rash has a pattern, so it's called blotchy, bright red maculopapular. And rash starts behind the ear, then go to the face, and then go to the whole body. So it's not fluid filled like the chicken pox. It's kind of like this. So it's a maculopapular rash, starts behind the ear, then go to the face, and then go to the whole body. And it will be like, it looks like the rash is confluent with each other. And the child will look miserable because they are quite unwell with this. Okay, so that's usually how measles usually starts. So first prodromal and then the rash stage. And you can see this one. So having conjunctivitis, so red watery eyes, runny nose, and then the rash. So how to confirm measles? So if you want to confirm measles, there is usually nothing you need to do. It can be just confirmed clinically because diagnosis is usually clinical. But if you are not sure, you can do a blood test. So you can do a measles IgM serology test, or you can also take a nasopharyngeal swab or check the urine for measles PCR. So any of this will work. So either a blood test or a nasopharyngeal swab or urine, any of these, you can get the measles. Okay? Complications. So measles is often can be a very serious condition. So most common complication of measles is otitis media, then bacterial superinfection, pneumonia, diarrhea. Okay. Sometimes measles can be complicated with encephalitis as well, but it's not very common. But sometimes they ask you in the exam, what is the most common complication of measles? So then we go for otitis media or diarrhea. Treatment. There is no specific treatment because this is a viral infection. So for viral infection, again, symptomatic treatment. Sometimes we give vitamin A that can reduce the complication, but the treatment will be just symptomatic, just like any virus. And the school exclusion for measles is 5 days. Okay, so 5 days for the index patient and 14 days for the contact. Now, that is important to remember, and that becomes a bit confusing. So 5 days for the patient, 14 days for the contact. That's the school exclusion for measles. Prevention, again, vaccination can be given from the age of 12 months. So measles, mumps, rubella, so MMR, this vaccine is given routinely to everyone at 12 months. And then MMRV, so MMR plus varicella at 18 months. So this is how we can prevent measles. Now, again, you can give the immunoglobulin for contact who are immunocompromised and less than 12-month-old. So again, exactly the same. So if a child is less than 12 months, or if there is a immunocompromised contact, so those two groups can get a immunoglobulin. And if you give immunoglobulin, it should be given as soon as possible after the exposure. Usually we say within 48 hours. Any questions, guys, with the measles? Second molar is usually the common, Dr. Sheikh. Yes, so immunoglobulin if immunocompromised. Rubella. So rubella is also known as German measles. It's a viral infection caused by Toga virus. And it's not very bad, like it's not like very serious infection like measles, but definitely congenital rubella syndrome is very bad. We will discuss that at some point. And we discussed that in pediatrics first class, what is congenital rubella syndrome, right? So if you look over here, how rubella usually presents, rubella, same like chickenpox, rubella will not have any prodromal symptom. So they will usually present with a rash. And the rash is ideally maculopapular generalized and sometimes can be itchy. Very common finding for rubella is post-auricular lymphadenopathy. So if you look over here, so the rash is like this. So if you look over here, that it's mainly involved the central area. So the main clue to think of rubella in exam is post-auricular lymphadenopathy in a child who doesn't have any prodromal symptom, but have a rash which starts on the face and neck and then goes to the body and doesn't involve the lower leg, arms, and soles that much. Okay, so post-auricular lymphadenopathy is a very important clue to think of rubella in exam. Rubella, the treatment is symptomatic and patients should rest quietly until they feel well. Take paracetamol for fever and aching joint. Prevention is vaccination. So again, rubella vaccination comes with MMR, and MMR is usually given in child at 12 and 18 months. Child usually excluded until fully recovered or at least 4 days from onset of the rash. So from 4 days from the onset of the rash, the child usually should not go to the school. Okay. Next, parvovirus B19, very important for exam. So parvovirus B19 is also called erythema infectiosum or fifth disease. School exclusion for rubella, according to John Murtagh, it is 4 days, and that's what we will follow. Did you see 7 days anywhere, doctor? In here it is still 4, so why 7? When it is infected, immunoglobulin will not work. So when it is infected, it is antiviral. when it is just a contact, not infected yet, then immunoglobulin. Parvovirus B19, also known as erythema infectiosum or fifth disease, very important for exam, but it's easy to diagnose. So it's also known as slapped cheek syndrome. So it is a condition caused by parvovirus B19, common in school-going children. So the patient usually has a prodromal symptom for few days. So fever, runny nose, headache. And then 2 to 5 days after this prodromal symptom, patient starts to have a rash. The rash is bright red macular rash. First start on the both cheeks like this. And it looks like someone has slapped the child. And after that, the maculopapular rash will appear on the whole body. Now remember, this is not centripetal like others. The rash is more common on the extremities than the trunk. Okay, so this is a lot of clues are here. So you have got erythematous rash on the cheeks, and then the rash appears on the extremities, not that much in the trunk. Okay, so that's parvovirus B19. So parvovirus B19 in pregnancy can be quite tricky. Comes in exam a lot. So for someone, like even for a child, parvovirus B19 is a mild viral infection. But if parvovirus infection occurs during pregnancy, there might be a lot of fetal complication, even miscarriages can occur. So it is advised to avoid close contact with pregnant women. Now, if a pregnant woman comes in contact with someone who has parvovirus positive, what would you do? That means now the pregnant patient is a contact, right? So you will first do some serology. So you will check the IgG and IgM. So all of you know that IgM is mainly found in recent infection, and IgG is found in chronic infection or if the patient is already immune. Now, if you found that patient, like you have done the IgM and IgG, you found IgG is positive and IgM negative, that means patient is already immune to this. But what if you found IgM positive? Two things can happen. One, that it is a falsely positive test, or patient has got early infection. In that case, because it can be false positive, you would do a repeat serology in 2 weeks' time. And you would check for if this IgG titer is rising. If nothing is there, both IgG and IgM is negative, it's better to repeat the test again in 2 weeks to see if there is any change. Okay, now that's very important to remember because it comes in exam. So always remember, if there is a pregnant patient comes in contact with a rubella infected patient, then you would need to do this serology test, IgM and IgG. If IgG positive, that means patient is already immune. If IgM positive, you have to repeat the test. If both negative, still you have to repeat the test. So if, let's say, the pregnant mother is infected with parvovirus in the first half of pregnancy, the fetus has a risk to develop hydrops fetalis and anemia. Women in this situation should be reassured that less than 5% women will miscarry and ultrasound monitoring will be done throughout the pregnancy. Okay, so you can always reassure the mother that even though if they have got parvovirus infection, doesn't necessarily mean that they will miscarry. Less than 5% will miscarry, and about any other problem like anemia, hydrops fetalis, those will be monitored by ultrasound. So they don't just need to go for a abortion for this kind of infection. For parvovirus B19, once the rash appears, the child is no longer infectious. So that's why there is no need of any school exclusion in parvovirus infection. Okay? Clear everyone with the parvovirus? Now, the next one is roseola. Roseola infantum. So, roseola infantum is known as 6 disease. So, it is caused by human herpes virus 6. So, how it happens is that roseola infantum, it is very classic presentation. So, sudden onset of high fever up to 40 degrees Celsius. And then 3 days later, there is no more fever. So, fever subside. And then a red maculopapular rash starts and largely confined to the trunk and limbs. Again, roseola infantum, it starts with a high fever, fever subsides, followed by a rash and kind of a maculopapular rash on the trunk and the limbs. And that's usually how it presents. It usually spares the face. Now, infection runs a benign course, although sometimes febrile convulsion can occur. So because the temperature can go high as 40 degrees Celsius, sometimes this condition can get complicated with febrile convulsion. Okay. Now, the child will no longer be infectious by the time symptoms appear. So again, for the 6th disease or roseola infantum, there is no need of any school exclusion. Hand, foot, and mouth disease. Hand, foot, and mouth disease is caused by Coxsackie A virus or enterovirus. So this is also a viral infection, and hand, foot, mouth. So the name suggests where will be the rash. The rash is a vesicular rash, so fluid-filled rash, and then it becomes ulcerated. And it mainly involves the hand, so palms and soles, and the mouth. Okay? Because there will be ulcers and sores on the mouth, the child will be very irritable, and they might even stop drinking water. So there is a high risk in these patients to get dehydration. Okay, so children are infectious until all the blisters have disappeared. So now, according to RCH, they say that there is no need of any school exclusion, and also JM says there is no need of any school exclusion. If school exclusion is not in the option, sometimes we say that child can stay at home until the rash is like completely blistered, or until all the blisters have been dried up at least. Okay, how it looks like, let's have a look. So hand, foot, and mouth disease, so the child will have this kind of blistery ulcerated rash in the mouth, tongue, buccal mucosa, and also in the palms and soles. And that's it, nothing else. Okay? Next, scarlet fever. Now, I know that this is quite overwhelming for many of you because it is very difficult. Just remember that this is one of the chapter that you have to read just the night before your exam, because it is lot. So don't think that you will be just able to memorize everything just now. The main thing at the moment is that if you are understanding what we are talking about, that's it. So don't feel quite overwhelmed because you are just learning these things. Okay? So the main basic is, are you understanding what we are talking about? And if you are, you are good. And we'll go for a summary after finishing this chapter. Okay? This is Dr. Walid. This is from John Murtagh. We are actually going through John Murtagh at the moment. and John Murtagh is enough. Scarlet fever. Scarlet fever results. Now, until all of this, we have been learning about viral infection, but scarlet fever is a bacterial infection caused by Streptococcus pyogenes. Now, there is a classic presentation of a scarlet fever. It always starts with some prodromal symptoms. So, sore throat is the first thing because this is caused by group A Streptococcus, and group A Streptococcus is notorious to cause sore throat, right? So, child will have sore throat, fever, malaise, headache, vomiting. So, all the features of like a flu. After that, there will be a rash. The rash has a particular feature which is called sunburned appearance or boiled lobster, blanches on pressure, and it's more prominent in the skin fold areas. Look at here. So scarlet fever, first the child had a sore throat, fever and everything, then 12 to 24 hours after that, child has got a rash, which is maculopapular, but it has a classic name called sunburned appearance. And it's more prominent in these spots. Okay. It mainly spares the perioral area. So circumoral pallor is common finding. And you can also get a strawberry tongue in this patient. I'll show you later on what is a strawberry tongue. Okay. So again, scarlet fever is a bacterial infection. So first fever, sore throat, malaise, followed by a rash. Rash spare the perioral area, but it's mainly sunburned appearance or red lobster, and then it's more prominent in the skin folded areas. So absence or spurs on face, palms, and soles, circumoral pallor, these are common, and it can also feel like a sandpaper. This is a bacterial infection, so treatment is antibiotic, so phenoxymethyl-penicillin for 10 days. And child can return to school 24 hours after starting the antibiotic. Okay, so that's scarlet fever. Questions? Everyone good? Kawasaki disease. Now, Kawasaki disease is not a viral infection, not a bacterial infection. It's called multisystemic vasculitis. So it's an inflammation of the vessels, and it can affect almost any kind of vessels in the body. But it is notorious to affect the coronary arteries. It's common in children under 5. So how it presents? So it is difficult to diagnose, but there are some criteria that you need to memorize. So child will have a fever more than 39 degrees for 5 days. Along with that, if they have 4 out of 5 criteria, you can diagnose them as Kawasaki disease. So fever above 39 plus 4 out of 5 symptoms. So what are those 5 symptoms? Maculopapular rash, and rash will be polymorphous, so different size and shape. Bilateral conjunctivitis, but non-purulent. Then dry cracked lips or a strawberry tongue. Edema of the periphery, so palms and soles will be swollen. And cervical lymphadenopathy, which is unilateral, tender, non-purulent. Now let me show you a picture, and that will make a lot of sense. So this is how the Kawasaki disease patient will look like. So if you see here, you can see the conjunctivitis, but non-purulent. So bilateral non-purulent conjunctivitis, dry cracked lips, strawberry tongue. This is called unilateral cervical lymphadenopathy, which is non-purulent but tender. Maculopapular rash, the rash will be different in size and shape.
erythema or redness of the periphery. So palms and sole can be red, and palms and soles can be swollen or edematous. So if 4 out of these 5 symptoms are met, along with the fever above 39, you can diagnose it as Kawasaki disease. Okay? Now, diagnosis is clinical, but this can mimic a lot of other conditions. So there is no specific test that can confirm the diagnosis, but you'll do some tests to rule out other conditions. So we do some tests like full blood examination, inflammatory marker. You can sometimes even get thrombocytosis, which means the platelet count can get high. Neutrophilia, so the neutrophil count can go high, anemia, hypoalbuminuria, all of this can happen, but this doesn't actually mean anything. So if the exam asks for an investigation, so you should choose a full blood examination or inflammatory marker if they ask. Usually they don't. But very, very important thing is that this condition can cause vasculitis, right? And it can cause coronary aneurysm and ectasia, which left untreated can cause ischemic heart disease and sudden death. So this is a condition which can be quite serious if it is left untreated. So the major complication of Kawasaki disease is vasculitis, causing coronary aneurysm and causing ischemic heart disease or sudden death. And this coronary aneurysm usually develop between second week to second month. So what we are supposed to do in this patient is that when you are diagnosing this patient, you will do a baseline echocardiogram, and then you would do another in 2 weeks and 6 weeks. And that's according to the RCH guideline. So echocardiogram, discuss with cardiologist, but suggested schedule of echo is at presentation, at 2 weeks, and at 6 weeks. Okay? And these are all the tests that we do in a patient who can have this condition, but it's not important for you to know. Now, the treatment. So you have learned that there are symptoms specific for Kawasaki disease. There is no way that you can confirm it unless if your patient met all the criteria. Investigation. So initially you can do full blood inflammatory marker, but the most important thing is to get the coronary aneurysm by doing an echocardiogram as a baseline at 2 weeks and 6 weeks. Treatment. Once you diagnose this patient, the best treatment should be immunoglobulin. And you can give aspirin, methylprednisolone, but the main treatment is immunoglobulin in this patient. Okay? Not super important for exam, but you should know at least. Clear everyone with the Kawasaki disease? Yes, so echocardiogram is supposed to detect the aneurysm. Very good. Mumps is not important. Pertussis. Super, super important is pertussis or whooping cough. So whooping cough is a respiratory infection, and it's kind of a bronchitis caused by a bacteria, which is Bordetella pertussis. Now, pertussis vaccination is available in Australia, and that's why there is not a huge amount of child who suffer from pertussis. But again, the pertussis vaccine does not give 100% immunity. So even if a child has got vaccine, still they can end up having a pertussis. Okay? So it is highly infectious, and it mainly spread through the respiratory droplets. So what happens is that children who get pertussis, they get a chronic cough. So the cough can persist months and months. That's why it is called 100 days cough. So initially, classic whooping cough is characterized by cough and coryza for a week. So initially the child might look like a normal flu. So they will have runny nose, bit of a cough, and then the child will get a very pronounced cough, and the cough will feel like whoop. So child will have a whooping cough, and most importantly, child can vomit after coughing. So cough, cough, cough followed by vomiting. That's one of the common presentation for pertussis. Okay, so chronic cough in a child initially started as just a mild cough and runny nose. Then it turned into a very vigorous cough, and it's not persistent. It's like a sudden episodes of cough or coughing fits. And then apart from the cough, the child is completely fine in between the cough. But when cough starts, it just goes on, and child needs to vomit after that. So that's the classic pattern. Okay. So it is highly infectious. And the most common cause of death from pertussis is pneumonia. Sometimes it can get complicated with seizure and encephalopathy. Diagnosis is clinical, but if you are not sure, you can confirm it by doing a nasopharyngeal swab and send it for PCR. Again, according to RCH, if a patient presents less than 3 weeks of cough, then the test will be nasopharyngeal swab for PCR. If a patient presents 3 weeks after the cough, then you would do a pertussis serology. Treatment. Treatment is important. The treatment can be any of these. So azithromycin, clarithromycin, erythromycin, that's usually the choice of antibiotic. Okay. All infants under 6 months and older children who gets complication. So complicated pertussis is pertussis with apnea, cyanosis, pneumonia, or encephalopathy. So if a child who is less than 6 months having pertussis, or older children with these complications will need to be admitted in the hospital. Okay. Now the treatment means the index case, that means the patient will get this treatment. What about the contacts? So if the cough is less than 3 weeks, you do the nasopharyngeal swab. If cough is more than 3 weeks, you do the pertussis serology. Now, the contact treatment is very tricky, and it has recently been changed. Previously, we used to give antibiotic to all the contact, but nowadays, it's only if there is a high risk contact, then we would treat it. So who are high risk contact? Those with, like those who are vulnerable. So according to the RCH, I'll show you from RCH because it becomes easier for you. It's not very well written in GEM. So if you go to RCH, so write pertussis RCH, and then we go to RCH. So if you see the RCH mainly, so antibiotic is same, azithro, clarithromycin. If patient cannot tolerate azithro or clarithromycin, that means allergy to macrolides, then we can go for Bactrim, which is trimethoprim sulfamethoxazole. Okay, so antibiotic prophylaxis of contact. Prophylaxis is aimed at preventing the infection to children less than 6 months old. So who will need the antibiotic? So we are now talking about the contact. Understand that, not the index patient. So contact who is a close contact, and the contact happened within 14 days, and the contact is either less than 6 months old, or the contact who had less than 3 doses of pertussis vaccine, household member less than 6 months old, or attend childcare in the same room and that infant was less than 6 months old. Now, making it easy for you, you would only give antibiotic in a contact if the contact is less than 6 months old, either at home or in childcare, or if there is a household member less than 6 months old, then everyone in that household will get the antibiotic. Again, let's say that a 4-year-old boy has got pertussis. Okay? Confirmed pertussis. The 4-year-old has a 3-month-old sibling at home. So that's a less than 6-month-old, and that is definitely a contact, right? So that contact will need treatment, and most of the time, if there is a household member less than 6 months old, we just give antibiotic to all household so that no one gets infected, and that will protect this 3-month-old child. We also offer the treatment to pregnant patient in the last month of the pregnancy. Okay, but don't make it too confusing for you, because if you just go too much, then it can become quite confusing. But these are the criteria to start the antibiotic in contact. Not everyone will need the treatment. And what antibiotic? The same antibiotic. So azithromycin, clarithromycin, that is the treatment of choice for both index case and contact. Now, prevention. So prevention is by vaccination. So everyone in Australia, they get the pertussis vaccine at 2, 4, 6 months, then at 4 years, and then at 12 to 13 years, according to the National Immunization Policy. So according to the NIP, these are the time when every child is supposed to get the pertussis vaccine. Now, after that, every 10 years, the patient is supposed to get a booster dose. Okay? So you will, if anyone in the family hasn't had that booster, you would advise that family member to get a booster dose. And every pregnant woman between 20 to 32 weeks is advised to get a pertussis vaccine. Whether they were immunized in the past or not, every pregnant woman should have this vaccine between 20 to 32 weeks. School exclusion is 5 days after starting the antibiotic for the patient, and for the contact, 14 days. Okay, any question with this? Yes, family members will have 7 days of prophylactic antibiotics. Vaccine to contact is only if their last booster is more than 10 years ago. Now remember, giving vaccine is not going to do anything to the contact. Because if contact is a household member, if you give the vaccine now, it may or may not protect the patient. Okay? So the idea is, if the contact is high risk group, then treat the contact as with the antibiotic. That's right, Dr. Faiza, you really got it. So if there is a 4-year-old child having a less than 6-month-old sibling at home, then all family members will get the antibiotic. Pregnant women will get the vaccine from 20 to 32 weeks. No, if a child missed the dose at 18 months, so if a child missed the dose, then they will actually have a catch-up schedule. So they can have that again whenever they want to. So they would not need to wait for 10 years. So they can always get a catch-up schedule and get it done. Okay. All right, guys. So that's more or less about pertussis. Complicated, but comes in exam. Impetigo. Impetigo or school sore is very common in Australia. Common in school. That's why it's called school sores. It is a bacterial infection of skin caused by staph or streptococcus. And it has a classic pattern of honey-colored crust. Let me show you. So see this honey-colored crust? So this kind of rash is what we call as school sore. Now, a school sore can happen anywhere. It can happen in the face, it can happen in the wrist, anywhere it can be. So don't just think that it will always be around the mouth. But if you see this honey-colored crust, that's the clue to think of impetigo. Okay? So it's a bacterial infection, so you need to treat it with antibiotic. So mainly if it is just one spot, then antibiotic is not needed. But when it is extensive, so mostly all over the body, patient has got the impetigo or school sore, then we go for oral antibiotic. So flucloxacillin or dicloxacillin for 10 days or cefalexin for 10 days is the treatment. So what if just one spot? For one spot, they can use a antiseptic ointment, which is Bactroban. Okay, so that's for like one spot in the leg. Then you would just give the patient with this topical antibiotic. But if there is multiple school sore, then the treatment of choice will be oral antibiotic. So child should be excluded from child care until antibiotic has been started. So once you start the antibiotic, child can go back to school. Head lice. So all of you know what is head lice. The only question comes in exam is the treatment. So initially, head lice can be treated with insecticides. So any of this, maldicin, permethrin, pyrethrin. If that doesn't work, you try one time, that doesn't work. A second application after 7 days can be tried. Still did not work, that becomes a resistant lice. For resistant lice, we can try cotrimoxazole. So cotrimoxazole is usually treatment of choice for a resistant head lice. And that's all about your school, like all the childhood infection. Okay. Any questions, guys? Index case always get antibiotic, not immunoglobulin. Immunoglobulin is only for some of the contact. Okay. Yeah, mupirocin, Bactroban is same. Resistant lice is treated by cotrimoxazole. Yeah. So for pertussis, the infected patient will get treatment with antibiotic, which is azithromycin, clarithromycin, any of them. For contact, the only time the contact will require prophylaxis if it is a high-risk contact. High-risk contact can be if the contact is less than 6-month-old, either at home or childcare, or let's say that there is a less than 6-month-old child at home, then what we normally do is that all family members get the antibiotic, because if one Like if one family member get the infection, then all others can get it, and that less than 6-month-old can also get the infection. Because less than 6 months, they are not fully immunized, they have high risk of developing complication. So that's why we say that if there is a less than 6-month-old child who is a contact, then we just go for like treating the whole family members. That is the only time you would treat the whole family members if in that family there is a less than 6-month-old. Okay, does it make sense? Okay. All right, so to recapitulate what we have learned, so chickenpox, it's a vesicular rash, no prodrome. The rash is a centripetal distribution, and school exclusion is 7 days or until the rash is dried. Then we have got measles. So measles is definitely prodromal symptom with 3 C's, coplic spots, and then the measles will have this kind of blotchy red rash, and child will be very terrible, right? And measles, how long will be your school exclusion? 4 days, 4 to 5, right? But 4 days. Now, measles, mumps is not really needed, rubella. Rubella, we know that there is post-auricular lymphadenopathy, and then they can have the rash on the face and then the trunk. So you've got measles, mumps, rubella done. Then we have got parvovirus B19, which is the slapped cheek syndrome. So initially the child will have a bit of a prodrome, followed by like a red rash on the cheeks, and then the rash appears on the limbs, not on the trunk. And there is no school exclusion. Then we have got Roseola infantum. Roseola infantum comes with high fever, sudden high fever, 40 degrees Celsius. Fever subside and then the rash appears. Okay. What else we have got? So scarlet fever, sore throat, followed by a rash 12 to 24 hours later. It has a sunburned appearance and it mainly prominent on the skin fold, strawberry tongue, perioral pallor. And 5 days after starting the antibiotic, child can go to school. Right? Am I wrong? I forget these things. These things are really bad. I think it was 24 or 5. 24, sorry. Yes, child can return 24 hours after taking the antibiotic. Then we have got Kawasaki disease. We know the pattern. So 39 degree above fever with 4 out of the 5 symptoms. So that's mainly it, but don't forget about the echocardiogram for coronary ectasia. And also the main treatment is immunoglobulin. We talked about the pertussis already. And then we have got impetigo. We talked about it, head lice. That's mainly all about it. All right, so let's take a 10-minute break, guys, and then we will start with rest of it. Thank you. Go through this table and it will give you a good idea. So you can see measles 5 days. No, sorry, it is not 4 days. Measles is 5 days. Mumps 9 days. Pertussis was 5 days after starting the antibiotic. Okay. So go through this chart once you finish this and it will make a lot of sense. Yeah, strawberry tongue can be on both scarlet and Kawasaki. Thank you. 10-minute break, guys. All right, everyone, let's start again. So now we're going with chapter 89 from John Mortag, which is emergencies in children. So for emergencies in children, the important things are already given in the notes. So if you open up the note, you will see all the important topics are giving. So in your class 1 note, there is not the full of it. But if you open the lecture 2 note, then you will be able to find out the rest of it. Okay. So what I would do is that I will mainly go with the John Mortag now, and then I will show you the lecture note and you can go through that. So if you come to page 1027, you would be able to see this one. So before that, there is nothing really important. So solid foreign objects in children. So children can swallow foreign objects time to time, and it can be quite tricky to manage. The high-risk foreign body, the most important one is button batteries. Any large objects more than 6 centimeter long, magnet, more than one magnet is always serious. So a golden rule is natural passage of most objects entering the stomach can be expected, which means that once a foreign body reach the stomach, it can usually go out of the system. Which means that not just stomach, if it passed the pylorus of the stomach, pylorus is the narrowest point of the stomach. So once it pass from the pylorus, most likely it will be able to pass through the bowel and then come out with this stool. Okay. So what will be the management for a solid foreign objects? So but by swallowing, it means that it entered into the esophagus, then it went into the stomach and then the other part of the gut. So most of the time we can do a conservative management in these children. So you will do a X-ray from mouth to anus when the child presents to find out where exactly is the foreign body at the moment. And then you would watch for the passage of foreign body in the stool for the next 3 days. Now, if after 3 days, still there is no foreign body passed out, then you will reorder another X-ray in a week, just to see that where it is moving. Now, if a bland foreign body is stationary for 1 month, even without any symptom, you have to remove it by laparotomy. Okay. In our trial class, when we did a question solve tips and tricks, we discussed about the foreign body inhalation and foreign body ingestion or swallowing. There is a bit of more to it. It's not just what we are discussing in here. So there are discussion on that link that we have discussed. So we discussed about like when to go for endoscopic removal, when to go for laparotomy. So there is a specific guideline for that. So if you have missed that class, please go to that class, find out what we have discussed about this topic. Okay. But as a rule, foreign body inhalation, especially if it is not a high risk object, like not button batteries, if nothing is like this, so if it is not a high risk foreign bodies, the rule is just a conservative management. Okay, so initial X-ray, advise the child or advise the parents so that they can have a look in the stool for the next 3 days for any foreign body. If there is nothing past, reorder another X-ray in a week. And even after a month, if it is just not moving at all, then even without symptom, it has to be removed by laparotomy. And Dr. Midhat, the guideline, we discussed that in our question solve tips and tricks class about a little bit more discussion about how to manage the high risk bodies or how to manage the high risk foreign bodies. So please go through that class if you have missed it. Moving on to fever. So fever can be there for a long, like a lot of things can cause fever in a child. But always remember, if an infant having fever and you can't find out any specific cause of infection, and it is a less than 3-month-old child, you will always consider a full septic workup. And you would admit the child in the hospital to find out the source of infection. So less than 3-month infant, no focus of infection, but there is fever, a full septic work has to be done because you want to rule out septicemia. And one of the important cause of septicemia in a child like this is meningitis. So you have to consider all of the possibilities in this case. Febrile convulsion. So febrile convulsion is when a patient gets fever, especially when a child gets high fever. In response to high fever, sometimes children can get a convulsion. So let's say the child has got a upper respiratory tract infection, and following the upper respiratory tract infection, the child got high fever, and in response to high fever, the child has got seizure or convulsion. That is what we will call as febrile convulsion. It's common in this age group, but it can happen in any age. Now, febrile convulsion is well written in RCH, so you need to go through that. So if you go to RCH, you can see that most of the febrile seizures are benign, doesn't require any investigation. So when a seizure happens, now remember one thing, febrile convulsion is not epilepsy. Epilepsy means that when seizure happens without any known cause. And to diagnose a child as epilepsy, you need at least 2 unprovoked seizures. That means 2 seizures without any cause. So it is not epilepsy because the seizure is caused by fever. Okay, so it is febrile convulsion, common between 6 months to 6 years of age. Sometimes even with a simple viral infection, it can happen. Febrile convulsion is divided into simple and complex. Simple one usually generalized seizure, so it involves all muscles of the body. Duration less than 15 minutes. Whereas complex febrile seizure, it's just focal, maybe just one part of the body gets the seizure. Duration can be above 15 minutes. So no investigation is usually required if it is a simple febrile seizure. But if you can try to find out what's causing the fever. If you don't know what's causing the fever, then again you need to do a full septic workup. So the treatment of seizure is mainly managing the cause of the fever. So why the child got the fever? If it is an upper respiratory tract infection, then manage the upper respiratory tract infection symptomatically, which means if there is fever, give some Panadol to reduce the fever. So just symptomatic treatment is all that you need to do. Now, what if the seizure is like it's getting prolonged? So if the seizure getting prolonged, especially more than 10 to 15 minutes, then you will need to be worried. So for seizure which is more than 10 to 15 minutes, you have to go for some medications. You can go for midazolam or diazepam. Midazolam can be given in any 4 routes. So IV, IM, intranasal, or even buccal. But most practical one, when patient is having the convulsion, is IM. And diazepam can be given so either rectally or IV. So if a patient having a febrile convulsion, but the convulsion is lasting more than 10 to 15 minutes, lasting more than 10 to 15 minutes, in those patients, you have to start with some of these midazolam or diazepam so that the seizure can be controlled. Okay, so to control the seizure, you can give either midas or diazepam. Any of these will be fine. There is a question which comes in exam that what is the risk of epilepsy in a child who gets febrile convulsion? According to John Murtagh, it is less than 3%. Let's see what is in RCH. RCH says that if the child doesn't have any risk factor, then just 1%. If the child has any of these risk factor, then even 10%. So that is a tricky area. So I always say follow RCH because it is the most updated guideline for pediatrics. But again, if there is a 3% in the option, then you would choose that. But always look at that if the child having any of these 4 risk factor, and if the question says that what is the risk of having epilepsy in that child, especially if there is a family history of epilepsy, is up to 10%. Okay, so JM says 3%, whereas RCH says no risk factor 1%, with risk factor 10%. So that's febrile convulsion. Dr. Sheikh, we are discussing from RCH and John Murtagh. That's all that we are discussing today. There is no Kaplan in our today's discussion. So this is your John Murtagh, and we are going into the RCH guideline, okay, which is just in the Google. Okay, moving on to meningitis encephalitis. So meningitis, all of you understand that meningitis is quite serious. So we are worried about bacterial meningitis, not about viral meningitis, okay? So any child who is especially infant less than 12 months, having a high fever, nausea, vomiting, having a purpuric rash, which is non-blanchable, that means when you give a pressure, it doesn't go away, and also quite drowsy, lethargic, you would be concerned about a bacterial meningitis. And what type of bacterial meningitis? Meningococcal meningitis, especially if there is a non-blanching rash. So if you suspect meningitis in a child, what would you do next? Your first thing is, if you can, get an IV line in and take a blood culture and start the child with IV antibiotic. That's the first thing you would do. So blood culture, if you can. If not, then just go for antibiotic. So blood culture, IV antibiotic. Once the patient gets a bit stable, then you can go for a lumbar puncture to confirm the diagnosis. For bacterial meningitis, along with IV antibiotic, you can also give dexamethasone. What type of antibiotic we prefer in meningitis? Ceftriaxone or cefotaxime. If that is not available, then you can go for benzyl penicillin. Okay, so that's meningococcemia. So if you suspect meningococcemia, the treatment should be started as soon as possible. Now, contact treatment for meningitis. Depends. So not all meningitis will have rash. Only the meningococcal meningitis usually gives this kind of rash. Okay. Now, even if there is no rash, but if it is an infant less than 12 months, having a high fever, drowsiness, vomiting, yes, you still would do a blood culture. But it is not the most important thing to do in that case. But definitely, if it is a rash with fever in a child, yes, you would do a blood culture as first. So, contact treatment. So let's say your patient has been diagnosed with meningococcal meningitis. You have treated that patient with antibiotic. What about the contact? So contact needs to be treated as well. So the contact who needs treatment is living in the same household and less than 2-year-old. So household contact less than 2-year-old has kissed this patient in the last 10 days or attended the same daycare center. So if any of this is the contact, they will need the treatment. And the treatment for contact is rifampicin. But let's say it's a pregnant patient who needs the treatment. Pregnant patient, you can't give rifampicin. Then you can go for ceftriaxone or ciprofloxacin, mainly ceftriaxone. Okay, so the main thing is contact treatment for most of the patient is rifampicin. Some other patient who you can't give rifampicin, you can choose ceftriaxone or ciprofloxacin. Okay, makes sense, guys? Now, the meningococcal meningitis, there is a guideline in RCH also. Please read that. Okay? Like if you go to meningitis RCH, so there is a meningitis guideline in here. It's important. So have a read about the management we discussed already. Complications, follow-up, those things. So this is the rash. You can see purpuric rash in meningitis. And they talked about what are the antibiotic that we give to the index patient. About the chemoprophylaxis. So if your patient has got Neisseria meningitis, then the treatment is either ciprofloxacin as a single dose. Young children can have rifampicin for 2 days. Pregnancy or contraindicated to rifampicin, you can go for ceftriaxone or ciprofloxacin. Okay, so basically rifampicin, but for pregnant patient, we can go for any of these two. Okay, so that's your guideline from RCH. You can give it a go. Moving on. Acute epiglottitis. We will discuss about those CSF finding later on, Dr. Yantan. Should we know the doses? No. Lumbar puncture finding. So we discussed that in our infectious disease class, not today. Yes, you would need to learn these guidelines. So anything we are discussing from RCH, yes, you have to go through them. Acute epiglottitis. Acute epiglottitis is caused by Haemophilus influenzae. Tell me if Haemophilus influenzae is a virus or bacteria. What do you think? It's a bacteria, right? Yes. So no, it's not viral. Remember it's a common mistake. Haemophilus influenzae is a bacteria. It's not influenza. So acute epiglottitis is caused by a very bad infection, which is caused by this Haemophilus influenzae. It's a life-threatening emergency in a child. Child will look very, very unwell, toxic, high fever, and with the expiratory stridor. So how we diagnose epiglottitis? Epiglottitis and croup, sometimes they can get confusing because both have this stridor. So epiglottitis, the stridor is expiratory stridor, whereas croup has inspiratory stridor. But there is a huge difference between these two. So epiglottitis, the child will have very high fever, toxic looking, and they don't have a cough. but they can have because their throat is so inflamed, they usually prefer not to move at all. So they sit quietly with leaning forward, and there is a name for that called tripod posture. So they don't move their head, they just keep quiet, doesn't move at all, leaning forward, and you will see that they are having drooling of saliva. This patient sometimes can also complain difficulty in swallowing because the inflamed epiglottis can start compressing the esophagus, causing the swallowing difficulty. Okay, so very high fever with the expiratory stridor, patient having shortness of breath, and having this drooling of saliva, sitting in leaning forward position, that's epiglottitis. Okay, croup. So croup is different. So initially, croup will have a bit of simple flu-like symptom. So croup will present with like a, let's say that the patient will have mild flu-like symptoms. So a little bit of cough, mild fever, runny nose. So it will look like a simple flu, but 3 to 4 days later, that cough will become kind of a harsh barking cough. So when that initial cough change into a harsh barking or brassy cough with the inspiratory stridor, that's the time you would think of croup. Okay, so that's how we differentiate between these two. Croup is usually caused by virus, and epiglottitis is caused by bacteria. Management. So if it is epiglottitis, management first is because their airway is completely blocked, you have to intubate the child. So nasotracheal intubation followed by antibiotic. So either ceftriaxone or cefotaxime. How about croup? So croup caused by parainfluenza virus and RSVs, that's the most common ones. And we talked about how they present treatment. So croup treatment depends on the severity of croup. So you have to find out from the stem, is it mild, moderate, or severe? So mild to moderate is same treatment, severe is different treatment. So first think about what is severe croup. Severe croup will have marked respiratory distress. They will be irritable, cyanosis, and quite exhausted. The main thing is mental status of the child. So severe croup child usually will be very exhausted. And the question will say the child looks irritable, drowsy, lethargic. So mental status change is the most important indicator of severity. Not how much is the stridor. Stridor will be there in every group, mild, moderate, severe. Every group will have a stridor. So whether the stridor is very loud doesn't make it severe group. Remember that. Okay. So mild to moderate, they will have a stridor, but they will not have any mental status changes. Okay. So if it is mild to moderate group, you will admit the child to hospital, give 1 dose of oral steroid. So steroid can be given as dexamethasone, can be given as prednisolone, or even by a budesonide inhaler. So one is IV, one is oral, and another is inhalation. Any way you can give a single dose of steroid. And then you wait for half an hour. If after half an hour the child is stridor free, then you can send the child back home and you can give the mother another dose of steroid. If in case child is still having a little bit of symptom, the next day the mother can give a second dose of steroid to the child at home. I'm talking not from John Murtagh, but from RCH. So that is what is written in RCH. So you have to read group from RCH as well. Again, so mild to moderate group, you start with single dose of steroid. If you give steroid and after half an hour the child is stridor free, then the child can go home with a second dose of steroid in the next day if still there is a bit of symptom. Okay. How about severe croup? So severe croup, the child will be cyanotic, hypoxia can be there, agitated, lethargic. The main treatment for severe croup is nebulized adrenaline, not oxygen. Remember it, nebulized adrenaline is the first line treatment. And this dose you need to remember. Not all dose come in exam, but adrenaline dose comes in exam. So the dose of adrenaline for severe croup is 0.5 mil per kilo per dose. Okay. And along with the adrenaline, you can also give dexamethasone or a steroid, but the main treatment of choice will be adrenaline. Any question, guys, so far? Okay. Wheezing in infant less than 12 months. So if you get a child who has wheezing and the child is less than 12 months, your most likely diagnosis should be acute bronchiolitis. Okay. So what is acute bronchiolitis? It is a viral infection ideally caused by RSV. So initially the child will have like simple flu-like symptom, cough, runny nose, and then 3 to 5 days later, the child will get worse. And child will start to get shortness of breath. Child might stop eating and drinking, getting more and more restless, agitated, drowsy. And most importantly, shortness of breath with wheezing of like wheezy sound. So when you get that kind of children, that's the time you would think of bronchiolitis. And if you listen to their chest, you will get two findings. One is widespread fine crepitation with expiratory wheezing. So if you get a widespread inspiratory crepitation with a expiratory wheeze, in this kind of children, you would think of bronchiolitis. Okay. Now, because bronchiolitis is a viral infection, you don't really need to do any investigation to confirm this. So you can do a lot of things, like you can do a chest x-ray, but chest x-ray should not be used or routinely performed. You can do a nasopharyngeal swab, but it's not routine. So normally we say that because it is a viral infection, you don't need to do any investigation to diagnose this because we already know what it is. So no need of blood test, no need of x-ray or even a swab. The only thing if you really want to do, if the child is looking very sick, child is not eating, drinking, you can assess their blood glucose to see if the child getting hypoglycemia. So when a child starts to get this kind of symptom, especially if you see the child having dehydration, child respiratory rate is more than 50, not eating and drinking, then the child has to be admitted. So the treatment is symptomatic because it's a viral infection. So symptomatic treatment, if the child is not feeding, you might need to go for NG tube feeding, or you might need to go for IV fluid if the child is severely dehydrated. Oxygen is only needed. So if the oxygen goes less than 95%, then you can start the child with oxygen by mask, or mainly with nasal prong, or even with a face mask. Remember, there is no role of antibiotic in this patient. There is no role of nebulized adrenaline, bronchodilator, or steroid. You might think that because the child having wheezing, why not we are giving some bronchodilator to open up the airway? There is no need. It will get better. Okay? Now, As per John Murtagh, it says less than 12 months, think of bronchiolitis, but you can think of bronchiolitis up to 18 to 24 months. Okay, so wheezy child up to 18 to 24 months, you can think of bronchiolitis if the symptoms goes with bronchiolitis. But after 2 years, bronchiolitis is unusual, then a wheezy child should be considered as asthma. Now, asthma is not going to be discussed today because there's a lot that we couldn't finish even, but we will discuss that at some point. So we're just skipping the very severe asthma. No, wheezing and stridor is different. A stridor happens if there is something wrong in the trachea or windpipe. But wheeze happens when there is problem in the bronchus or airway. Okay, like mainly the bronchus or the lungs. Breath holding attacks. So breath holding attacks, it's not uncommon in children. Yes, so less than 12 months is if it is a wheezy child, definitely you think of bronchiolitis. But even up to 24 months, you can think of bronchiolitis if the symptoms and sign goes with it. After 2 years, wheezy child usually should be considered as having an asthma. So breath holding attack is common between 6 months to 6 years. So what happens in some children, especially during this age group, so they can get quite dramatic, right? Especially 2 to 3-year-old child. So let's say they did not like something. So or in response to sudden shock, anger, frustration, like they wanted to have a toy, but you did not want to buy them. What they did, they started lying down on the floor, started crying heavily, and because they're crying loudly, at some point they started to hold their breath. So when they hold their breath, they no longer can get the oxygen, so they start to get pale and blue. And if it continues for a good amount of time, because brain is not getting enough blood and oxygen, they lose their consciousness and start to have a fit or convulsion. And the convulsion will be just less than 60 seconds. It will never be more than a minute. And it will not be associated with the classic epilepsy like biting tongue or having incontinence of urine or stool. So that is what we call as breath holding attack. Nothing you need to do, reassure the parents that these are fine, these will get better. It is not an epilepsy and it's not going to be an epilepsy. So just reassure the parents about it. Aspirated foreign body. So if someone, like if a child aspirate foreign body, so most common symptom is choking episodes. So let's say the child was eating a nut or some kind of food, and suddenly child started to have coughing, wheezing, and choking. Okay, so persistent coughing, choking, wheezing following having a food, or maybe child was playing with something, that will lead you to think of aspirated foreign body. If you examine their child, you might find out that one part of the lung doesn't have any breath sound, and you can get unilateral wheezing in that child. Investigation, so you want to do a chest X-ray to find out where exactly it is. And most of the time, child should be able to cough out the foreign body, so encourage the coughing. And sometimes we can do Heimlich maneuver if the child is more than 8 years. So lots of things can be done. If it is complete obstruction, then you have to remove the foreign body with forceps. Still unsuccessful, maybe even the child might need a tracheostomy or cricothyroidotomy. Okay. Anaphylaxis. No, breath holding attack does not cause any brain damage. It's fine. You don't need to memorize the drug, Dr. Shabir. Anaphylaxis. So a lot of time, children can have a sudden anaphylactic shock. So let's say that there is a bee sting for the first time. And in response to bee sting, the child is getting into a hypovolemic shock. So anaphylaxis will present as a circulatory collapse. Along with that, the patient will have swelling of lips and tongue, shortness of breath, dizziness, confusion, even sometimes loss of consciousness. Along with that swollen lips and tongue and wheezing, shortness of breath, patient will have shock. That's anaphylaxis. And it usually happens within minutes of something that patient is severely allergic to. So what is the treatment of anaphylaxis? Again, it is the main treatment is adrenaline. You have to memorize the dose of adrenaline. So it is 10 microgram per kilo, 1 in 1,000 concentration. Okay, so that's the treatment for anaphylaxis. And that's all about your emergency condition in children. There is one other condition called SIDS, sudden infant death syndrome. So if a less than 12-month-old child suddenly pass away without any known cause, that is called SIDS. There are lots of risk factors for having a SIDS. You can go through that, but the question that comes in exam is the management. The main thing that comes in exam that because there is no identifiable cause of death, any SIDS children has to be involved with a police officer and a coroner. So coroner is someone who is going to find out that what might have caused the death of the child, and this child will need a autopsy, whether anyone wants or not. Okay, so the police and coroner has to be notified, and the law requires an autopsy in this case. So that's all about emergency in children. No, it's not facing the cause. It's mainly just finding out the cause. Most of the time, there is actually no cause. And that doesn't mean that the parents needs to face the court. Okay. Parents cannot deny the autopsy. This is mandatory. Now, one thing I wanted to let you know, um, in your schedule, there by mistake we have given a class tomorrow. There will be no class tomorrow. Okay, we will change that schedule. I will give you an updated schedule. Okay, so there is a little bit of mistake when I made this, but there is no class tomorrow. The next class with me will be Tuesday as scheduled. Okay. I haven't finished the lecture, guys. So I have started this pediatric class 2 notes. So we finished all of this. Moving on to respiratory conditions. So respiratory conditions, most of the things we have discussed already, especially croup has been discussed, epiglottitis has been discussed. Remember one other thing, that laryngomalacia. So laryngomalacia is the most common cause of a stridor in infant. So it's a laryngeal anomaly. And in this case, the children will have a specific, like a loud cry. Okay. And so mostly that when they cry, the stridor will get worse. So that's usually a clue to think that this might be laryngomalacia. So question usually asks, what is the most common cause of stridor in infant? So that's laryngomalacia. Cystic fibrosis, I'll just touch this because these are not super important. Cystic fibrosis is a autosomal recessive condition. So you understand that this is mainly a hereditary condition. In this condition, the children usually have a severe lung disease and they develop malabsorption. So there is a genetic mutation which mainly affect all the juice secretion from the body, you can say. Okay? So the pathophysiology is that epithelial cell unable to secrete the chloride, and that causes failure to clear mucus secretion. So everywhere, like from the bronchus, there is mucus secretion. So there is always mucus secretion from lots of areas of our body. And those mucus that in a normal patient, usually their mucus is quite thin, so it can be easily cleared. But in patient with cystic fibrosis, the mucus, the digestive juice, these become very thick that patient is unable to clear it. Okay? Because they can't clear this mucus, they can end up getting a lot of lung infection and eventually bronchiectasis and chronic chest infection. These patients also have pancreatic juice insufficiency causing the malabsorption. So they get this frequent, bulky, greasy, hard to flush, foul smelly stool. Okay? Lots of other things can happen. They can't absorb the fat. So fat soluble vitamin also can get deficient. This patient can have recurrent diarrhea because of malabsorption causing rectal prolapse. So the main cause of death in this patient is the respiratory complication. Diagnosis, if you want to diagnose the cystic fibrosis, the initial test is sweat test. And if sweat test is unequivocal, then we can do this pancreatic function test. Not super important, you can just go through it. This is from John Murtagh. So you can see the patient can have malaise, failure to thrive, persistent respiratory problem, gastrointestinal problem. The male can be infertile because of atrophy of the vas deferens. So diagnosis, in newborn, every newborn is mainly have this kind of screening when they are born. And the screening that we do is immunoreactive trypsin. And it can detect cystic fibrosis in 75% cases. But sometimes the other 25% can be missed. So if you want to diagnose, then sweat test, where you can get elevated sodium and chloride level, and DNA test can be done for carriers. But mainly the investigation is sweat test. There is no treatment for this, and there is no cure. Yes, so respiratory tract infection, more common is lower respiratory tract infection, but yes, upper respiratory can be there as well. Pneumonia. Pneumonia is a very, very important topic for your exam. I know it is a bit late at the moment, and also you must be exhausted, but I have to finish respiratory system. Otherwise, I can't finish the other things in another class. Okay, so let me continue so that we can finish your pediatrics in 3 class. So pneumonia means chest infection. And in children, pneumonia less than 5-year-old, mostly viral infection, and above 5-year-old, they usually get bacterial infection. And the commonest bacteria that causes pneumonia is Streptococcus. So RCH has a very good discussion about pneumonia. You have to go through that, and I will show you as well. So there is a chapter in John Murtagh about pneumonia in children. And that mainly, I think it's in the dyspnea chapter. So if you want, you can go through that. But I mainly focus on RCH for pneumonia in pediatrics. And that's more than enough. So community-acquired pneumonia is the most common cause of pneumonia, right? So community-acquired pneumonia can be diagnosed clinically. Chest X-ray, blood test, microbiological investigation are not recommended for routine use. So just because you think someone has got pneumonia doesn't mean that you will need to do a blood culture, lots of blood tests, chest X-ray, or maybe even a swab. It's not routinely performed. Because if it is a non-severe pneumonia, your clinical diagnosis is enough. And you can just treat them with oral antibiotic. That's enough. The only time you would do some investigation if you think the patient has got severe pneumonia or complicated pneumonia. So what are the main features of pneumonia? Fever, cough. Mostly if it is a bacterial, the patient will have productive or chesty cough. So yellow-green phlegm. So fever, cough, shortness of breath, and chest pain. So these are the main 4 symptoms of pneumonia. On examination, you can get features of increased respiratory rate, oxygen saturation can go low, and you can also get features of consolidation on lung examination. So consolidation features are if you will get like reduced breath sound on the affected side, reduced chest expansion on that side, dull percussion note on that side, and most importantly, you will get increased vocal resonance. So increased vocal resonance and reduced breath sound or bronchial breath sound with a dull percussion note, you would think of consolidation. Okay, so that's your physical examination finding. How do we know if a patient has got severe pneumonia? There are criteria. One or more of these symptoms, if it is there, then we can call it complicated or severe pneumonia. So severe pneumonia, first of all, severe respiratory distress, marked tachycardia, so if the heart rate goes above 120, altered mental status, so patient is confused, oxygen saturation less than 80%, or complicated pneumonia. Complicated pneumonia is pneumonia which has been complicated with a parapneumonic effusion, so pleural effusion, or having a empyema, which means pus collection in the pleural cavity. So if any of these 5 is there, that will be termed as severe pneumonia. Okay, management. Investigation routinely is not recommended for mild disease where you can treat it as outpatient. Chest X-ray only needed if it is a severe or complicated pneumonia. That's important to remember because everyone thinks that just because patient has features of pneumonia, they just send the patient for a chest X-ray. It's not the case. And for severe complicated pneumonia, we do all the tests. So we do full blood count, blood cultures, swab, everything, but not for mild to moderate cases. So how do we treat pneumonia in a child? And that's what comes in exam. Try to get an idea from this chart. First of all, does this patient has severe pneumonia? So you know what is severe pneumonia means. So if any of those symptoms are there, if the child doesn't have severe pneumonia, then the treatment will be mainly oral antibiotics. So you can try oral amoxicillin Now, if the child is having ongoing vomiting, cannot tolerate oral food, then you have to send the patient to hospital for IV benzyl penicillin. But otherwise, oral amoxicillin or amoxicillin clavulanic acid is the treatment of choice. Okay, so mild to moderate amoxicillin, but only benzyl penicillin if the child is unable to tolerate oral intake or vomiting. If there is a feature of severe pneumonia, then child will be admitted and the antibiotic choice is ceftriaxone plus flucloxacillin. Sometimes we might need to even add vancomycin if we suspect MRSA. And that is what you need to remember. Okay, clear guys with the chart? This guideline is enough. We don't follow any other guideline except this one. Okay. All right. So this was the one that we would follow. Now, another thing is important to understand. If you suspect complicated pneumonia, let's say a patient who you have started with oral antibiotic, suddenly the patient is deteriorating. So if a patient with a known pneumonia with an oral antibiotic suddenly deteriorate, in that patient, you have to think of complicated pneumonia, and complicated pneumonia, the mainly parapneumonic effusion should be our first thing that comes in mind. So if a pneumonia patient suddenly get worse or just antibiotic is not working, then think that, well, what if the child has developed a parapneumonic effusion? So what would you do next? If you haven't done the chest X-ray yet, you do a chest X-ray to confirm if there is any effusion. If there is moderate or large effusion, or even a small effusion, but child is unwell, you have to start IV antibiotic in that patient. So previously you were using oral antibiotic, but child got deteriorated, and on a chest X-ray you found there is effusion. So you change it to IV antibiotic. Before you change it to IV antibiotic, take the blood for culture to know what organism is causing it. Once you have done with the antibiotic, do a chest ultrasound. Now, with the chest ultrasound, you will be able to know if it is a simple effusion or if it is a complicated effusion. Complicated effusion means if it is empyema. So in simple effusion, you can just continue the antibiotic for 2 days and see if the child is improving. If the child is not improving, or you see there is a features of complicated effusion, then you need to involve a respiratory physician for intercostal catheter, or we call it video-assisted thoracoscopic surgery, or commonly known as VATS. Again, you started IV antibiotic, then you do an ultrasound to quantify how much is the fluid and if it is simple or complicated. Simple effusion, you can continue for 2 days more antibiotic, see how the patient is doing. If deteriorate, or if there is already complicated effusion on the ultrasound, then you need to involve a respiratory or surgical team. And what they would do, they can do a intercostal catheter to relieve the effusion, or even VATS. Okay, so this is all about pneumonia, guys. So make sure you read from RCH. It is very important. And only thing that we haven't done from respiratory is asthma. Other than that, everything is done with our discussion from the emergency condition in children. Okay? And then now we can finish the class. Do you guys have any questions on our today's topic? And Totosavir 4-day-old 380 bilirubin. You would start with phototherapy. Use that nomogram. Based on the nomogram, you can choose. Can epiglottis present with vomiting as the primary symptom? Unlikely. Epiglottis primary symptom should be shortness of breath. Pediatrics class 3 will be next Tuesday. That's right. EPIC verification can take up to 3 months. Today's video will be uploaded within 2 days. Should I only follow JM and RCH? Yes, only JM and RCH for today's session. And only thing that we have discussed. That's it, nothing more. Kaplan is, in some cases, we go for the Kaplan, like not always. We mainly go for Kaplan sometimes for specific things. So I would not recommend for you, any of you to finish full Kaplan. It's not worth it. Okay, just the thing that we discuss is enough. Pathologic jaundice, we don't know. It depends if the jaundice started from birth, then it is pathological jaundice. Should we include police regarding all brought death case? Didn't understand, Dr. Viz. What did you mean? Is it about the seats? For all seats, yes, you have to involve it. Notes and RCH is enough, Dr. Muhammad Walid. If jaundice started for the first time on the 4th day, it is unlikely to be pathological. Pathological jaundice usually starts from day 1. But even if it is a physiological jaundice, if the nomogram goes, like nomogram is the main thing. So if you see that on the nomogram, the bilirubin is high, even if physiological jaundice will need a phototherapy. Okay? So it always depends on the photograph Dr. Fan has shared. No, more than 360 is for 24, up to 24 hours. So have a look, what did they say? Not, no, it did not say that. So nomogram has, your 4-day child is 96 hours, right? So 96 hours, you would start phototherapy around 3:30, you would start the phototherapy for that child. And that 360 is for up to 24 hours. 24 to 36, I think. No, for 96 hours, you would start exchange transfusion if the bilirubin is above 400. Below 400, you would go for phototherapy. I don't have any short quiz for today, Dr. Deep. Sorry, we don't have anything for today, but it's mainly the short thing was when we discussed that childhood infection. That was the short discussion of today's session, but we don't have anything like yesterday. All right, guys, so we'll stop it here tonight. You'll get an updated schedule. Remember, there is no class tomorrow. The next class is on Tuesday. Thanks, everyone. Yes, so the day that you see as a mock, there will be no class on mock test, but what we say that during that time, you are supposed to at least finish cardiology. So the mock test is mainly to give you an idea that if you haven't finished that topic yet, it means that you are a little bit behind. So you need to go up. You need to go a little bit more faster. But again, if you couldn't finish cardiology because you might haven't got the enough time, that's fine. The mock test will be there when you are ready. The mock test is in the portal, Dr. Walid. If any of you have missed our orientation class, you will be a little bit confused. So if any of you started a little bit late, you have missed our orientation class where we discussed each and everything about this MCQ preparation. I would like you guys first have a listen to that video, because if you are confused, most of the time that is what it is. So orientation video is the very important one. We did the initial 1 hour, we just talked and introduced. After 1 hour, we started talking about the MCQ preparation. So definitely read that if you have missed it. No class tomorrow. The next class with me will be on Tuesday. It was a mistake in your schedule. Thanks, everyone. Have a good night. Take care.